All right, welcome back to the podcast. A little series we're doing focused on older adults. We welcome Jackie and Kim back to the program. Welcome back. Good to see you all.
Thank you.
Nice to
Nice
be
to see
back.
you.
Last time we talked, we did have the number 5. It was the 5 best tests and measures for older adults in terms of fall risk. Today we're sticking with that theme of 5s, but something different. Exploring the 5 M's of geriatrics. This is a framework developed by Dr. Mary Tinetti and her colleagues to enhance the care of older adults. We'll share the resource in the show notes as well. But let's go through each of the 5 M's one by one and make sure the audience can walk away with an understanding of what each means and how we can maybe apply them to their care of older adults, according to Dr. Tinetti and her colleagues. So first up in the 5 M's, and this one was mentioned a lot in PT school, or I wish it was mentioned more, because it can have a pretty big effect. And the first one is medications or meds. And that is something that was brought up, but as you got to work with people, you saw what different effects medications can and regularly do have. So the first of the 5 M's in terms of medications, why does this one need to be on people's minds?
Well, medications affect functional movement, functional cognitive, mental function, cognitive function, physical function. So our ability to move can be impaired by medications or can be enhanced by medications. Think of our individuals that have Parkinson's disease, and they may need to be on carbidopa, or they need to be on Requip or some other medication to help improve their motor system so that they can then move more easily and try to control some of their dyskinesias. So those medications can help with movement, but also I can have someone that may have schizophrenia or have some type of bipolar disorder, and they're on medications to control those moods, and that could lead to dyskinesias, that could lead to tardive dyskinesia. And so we have to be aware of how medications, not just those that are for the motor system, but those that can affect the motor system, are working on the individual.
Yeah, this feels like I thought I understood the tip of the iceberg in terms of importance, and then you start to understand how this affects human beings, and it's having an understanding and being alerted to these things is terribly important. Number 2 feels like a nod to our entire profession, at least at first glance anyway. The second M we'll talk about is mobility. Jackie, when that one comes up on the list, why is this important to focus on for older adults?
So a person with a musculoskeletal condition needs to be treated holistically, right? That's something we could agree on. Like, yes. And it doesn't change because, how we would approach improving mobility doesn't change because that individual is an older adult. What happens, though, is that need for knowledge about age-related change and how that looks different than pathology. And so being able to understand someone's overall ability to move and how that affects their physical activity, can you figure out what is part of this pathologic process that I might be able to address versus something that comes along with maybe some changes this person's been experiencing over many, many years that actually doesn't contribute to the thing they're having trouble with, whether it's an activity limitation or some kind of impairment. So really understanding how you can not only recognize those age-related changes versus a pathologic change, but being able to stay ahead of age-related changes with appropriately dosing mobility and, strength and power and flexibility is really important. So I think mobility is just one of those terms that in this 5M framework kind of helps you realize that even if I'm treating this musculoskeletal shoulder condition in my older adult patient, I have got to consider how else they move in successfully, treating this person.
Ken, do you want to add something about mobility?
Yeah, I really like the way Jackie framed it in terms of it's, age-related changes, and then you have pathology on top of that. And then I'll take it a step further. It's either micromobility of like a joint and arthrokinematics, or it could be macromobility, their ability to move their whole person in space, whether it's upstairs or whatever other functional activity they need. I think if we pull back to how Mary Tinetti and this was originally started with age-friendly healthcare, which actually was initially 4 M's, the mobility part that they were looking at really was more a matter of trying to prevent immobilization that would relate with increased risk of pressure ulcerations, that would relate to increased risk of developing pneumonia, that would relate to increased risk of developing delirium in the hospital. And so they were looking at early mobilization and mobility at a gross level of, we just need to get them moving. But I think it's right in our wheelhouse as therapists, as movement experts, to say, well, what does it look like to help that person move better? And why is it so important to help that person move? And so I think the mobility M is really important. And I think from the physician point, it's important that they know mobility is important. So that way they will see more referrals and more consultations on the hospital side and within the other parts of within the healthcare delivery system. But then it comes to where the M comes to our profession is we're really honing in on the specifics of that mobility on a micro level, macro level, or whether it's what's causing that immobilization, whether it's age-related, whether it's even life choice. It could just be sedentary lifestyle. And we can then understand what we can do in terms of our intervention, because we need to identify problems, and then we can then address them. So the mobility M helps us to look at things in a different framework of not forgetting these other pieces.
All right, we've gone through medications, mobility. Third up, you already mentioned that word holistically and treating the entire person. Let's go to this one. When I say mind, Ken, why is mind one of the 5 M's? Why is it so important?
So the mind is really, we can't do anything without being aware of our environment and having a volition to move. And so being mindful of where we are, pun intended, is really important. And as a therapist, understanding what a person's cognitive function is or their status really helps to identify things that may be impairments. I think many of us, and I'm sure Jackie can attest, when we're in these facilities and we're working with individuals that may have a cognitive impairment, but they are as strong as a bull and they're able to get out of the chair and they're able to walk miles. And it's like, hold on a minute, we need to put them in a chair. We need to medicate them, these chemical restraints. Hold on a minute. No, chemical restraints is only going to cause more problems. No, they need to move so they don't get these other problems. We need to figure out how to make the system safe for them to move, given that they may not be aware of their surroundings. And so cognition is really important. Is what we're providing something that can be retained? Is it something that they can recall later on? Or is it something that they will always need someone to be with them for some type of supervision? So that's where the mind comes in, is being mindful of what our intervention plans can actually accomplish, knowing that could be a barrier. It also could be a facilitator. If someone's really aware of things, we may not need to go over something more than once because they got it.
When you hear about that M, Jackie, mind, is there anything you'd add?
Using mind as and your knowledge of mental health or cognitive status as a differential diagnosis. So there are health conditions like depression, advancing dementia, or even delirium, and each of these conditions have been mistaken for the other. And so to not be aware and mindful of what these symptoms, signs and symptoms are, and how are they acute? Are they not? Is this something that is different? That is something I should care about at the moment, and seek alternative input from a different team member on this person's team. So many times I have experienced someone being labeled as having advancing dementia after a change has been observed over the course of maybe 2 or 3 days. This is not how this works. This is not advancing dementia, and so it's just very necessary to include an assessment of cognition and baseline status so that a change is observed. And it's really just one of the systems. We do it for the other systems, so we do it for this one too. And so it does rise to the level of having an M because it's often neglected.
All right, before we get to number 4, I do want to say thanks and some great news from APTA Geriatrics. The Certified Exercise Expert for Aging Adults, also known as CEEAA, just rolls off the tongue, is now hybrid. That means you can get profession-leading knowledge without some of the travel and extra costs. Choose the hybrid path with one of the modules and live webinars, plus a hands-on weekend, or stick with the traditional in-person weekends. Either way, you'll gain expert skills to design effective exercise programs for aging adults. Elevate your practice and save time and money. Learn more at aptageriatrics.org. I'm guessing the 5 M's comes up somewhere in CEEAA. So let's get to that 4th M. This one, we start to get a couple words in there, which is multi-conditions. So what does this one mean, Jackie? Multi-conditions in that 5 M's.
So we're talking about multi-complexity. And I think that that is valuable because nobody is going to really have one health condition. There will be secondary ones and tertiary ones, and those that are tied for second and third, and so I don't even know the statistic. I'm sure it's over 50-60% of individuals over the age of 65 have more than 2 what would be labeled as chronic health conditions, things like cancer, chronic obstructive pulmonary disorder, asthma, diabetes, history of hypertension, having experienced a stroke. So these things have, consequences that stay with the individual, and so affect how they move, how they think, how they, interact with their world. So to have an understanding of when these health conditions had started affecting this individual, take diabetes, for example, if someone's been living with the complications of diabetes for a while, how have those been managed? I want to know what medications my client is taking. I want to know if I'm going to properly dose them with exercise, if they can handle that. If they experience hypoglycemic episodes, I don't want to find that out when it's time to give them orange juice. I want to know this ahead of time. So part of treating the whole person is knowing what other health conditions they have experienced in the past, which ones they currently manage, and how I can incorporate that management into what they need from me from a physical therapy standpoint.
Ken, I saw you nodding along as Jackie was talking about this M. Where's your head go?
So I agree with everything that Jackie's saying about the complexity. I don't know any of my patients, certainly in the home health world where they're homebound. I don't know anyone that has just one condition. Very rare. And that happens, but it is rare in our working with older adults. I would want to add that multi-complexity to me is really looking at how do we manage multiple conditions. And I think looking back with the physicians, it's how do I handle heart failure along with handling incontinence? I give them medications to get the water off the system, and now the person has greater incontinence symptoms. So they're not going to take that Lasix or that water pill because they don't like the fact that it's interfering with their other ADLs and they're embarrassed by it. So medication adherence is a problem that physicians would deal with, but I think it's also something that we need to be aware of when we're working with our individuals. We know treating one condition can make another condition worse. And so being aware of how all of these different conditions interplay with each other, and how does medication affect these things, or how does their mind affect these things? Multi-complexity just really pulls everything together and says, wow, this is a real complex case. There's a lot of things going on. We need to prioritize what's our goal, and we need to prioritize what the patient's goal is, and how do we help manage that patient so that they have a better quality of life. So that's to me what multi-complexity is, just pulling all the pieces together.
Okay, and this last one actually has 3 M's in it for the 5 M's. And again, this was from Dr. Mary Tinetti and her colleagues. And it's matters most to me. Help me understand this one. Ken, what do you got?
So ultimately, this is really being holistic and having patient-centered goals. So this, in terms of I keep referring back to where it came from with the physicians, but in terms of what matters most is being aware of advanced directives, being aware of the patient's wishes, what they want, what treatments they want, what treatments they don't want. And for the physician literature, it's more a matter of, do they want artificial nutrition? I don't want to be on life-sustaining. I don't want any life-sustaining measures. So it gets down that end of life type of conversation. I don't think it goes that far for us as therapists, but really it's a matter of dragging someone out of a chair to get them to ambulate when that is not their life goal. If they have difficulty ambulating, and for them being in a wheelchair is safe for them and appropriate for them, maybe we need to abide by that wish that, you know what, doing more types of things that I want may not be what's in that patient's best interest. And so I think that's where what matters most comes into us as therapists, is really being mindful of our intervention plan may not match the patient's goals, and we need to align with what the patient wants.
I caught you smiling a few times there, Jackie, with matters most to me. What would you add?
I would add that it's sometimes important to remind yourself as the therapist that it is the client you're treating, not their family. And a lot of times what the family wants does not align with what the patient wants. And so just, obviously I agree with you, Ken, and I think it includes planning for the future, but maybe the future is, what am I doing next week? Maybe the future is, look, you've recovered from this rotator cuff tear that you got when you fell. But if we didn't address the root cause, which is falling,
Right.
that got you to this musculoskeletal condition, then part of that planning for the future needs to what's important to this individual, and educating about what services are still available. So I think I have, two main take homes there. One is make sure that what your patient wants is what you're after. And if the family indicates something different, then maybe you can be the person that helps to align everybody. And then my second message is, has the root cause of why you're seeing that individual been addressed? And is there something that matters to your client that maybe seems to be secondary or tertiary to you as the therapist, but maybe, higher on a priority list to that client? They might not mention it unless you bring it up, especially something like falls that, might have a stigma to it, or something like incontinence that we don't want to bring up because we don't know what to do about it. So yeah, again, something that really, this 5 M's is really a framework, not that it covers everything you need to know as someone who works with older adults, but it does help to remind you, hey, did I consider this thing that's probably really important for this individual who is an older adult dealing with more than what they've been referred for.
And again, we'll share the link to that where Dr. Mary Kennedy and her colleagues highlight those 5 M's. Again, meds, mobility, mind, multi-conditions, and matters most to me. Again, want to say thanks to APTA Geriatrics, really modernizing that CEEAA, that industry profession-leading resource. Now in hybrid means you can get that profession-leading knowledge without some of that travel and extra costs. Choose the hybrid path with online modules and live webinars, plus a hands-on weekend that still stays there, or stick with the traditional in-person weekends. Either way, you'll gain expert skills to design effective exercise programs for aging adults. Elevate your practice and save time and money. Learn more at aptageriatrics.org. My favorite part of the show is called The Parting Shot. With these 5 M's, what would you want to leave with the audience? Ken, I'll let you lead off on this. What would your parting shot be in terms of these 5 M's? What do you think the audience should remember?
I think the audience should know that they're already doing all of these 5 M's. It's already been a part of practice. The 5 M's just really helps us to, like what Jackie just said, it helps us not to forget that we address all of those items.
All right, Jackie, your parting shot for the 5 M's. What do you got?
I love that. I'm sorry that my parting shot is not super unique, but I would just piggyback off of what you just said, Ken. And if you're a clinician, no matter the setting you're in, who works with older adults, try to maybe pick one time during your initial assessment that you incorporate this. You're not going to change the way you approach all of your examination, but if you can find that spot in, maybe in your history or at some point during your collection of data to say, oh yeah, by the way, really try to force yourself to call out if you're in fact covering these things for your older adult patient.
Love it. Jackie and Ken, thanks so much for breaking down those 5 M's with us.